Now I'll be more clear with my mic on. Good morning, friends. I hope you'll have attended the endo paper and it was easier as compared to the last endo series which you all had attempted. Easier only because probably you all have studied much more better than what you all must have attempted in Jan. Alright, so if you all can see on my screen, I have started with the question number 13. That's from where the endo section begins. The first 12 questions are related to conservative and dental materials, which in case if I have time at the end of today's session, we may come back to it. But since there are a lot of things which I would like to discuss of endodontics, in terms of files, in terms of anatomy, in terms of pathology, I would try to utilize my time discussing more relevant things for today's subject. Few things which will require a bit of more precise discussion. I would like you all to file your notes related to those questions. And few things which are very direct from the textbook, we will directly just discuss the answer and move on to the next one. So shall we begin? Alright, so the first question, efferent nerves found in the dental pulp are? The answer is B, that is sympathetic postganglionic fibers. Okay, now one question is always asked about your nerve supply for the pulp. Okay, so at this point you should know that there are only two types of fibers or two types of neural supply that is received by the dental pulp. The first one being sensory. Okay, in the sensory you have your A delta fibers and the C fibers, and the second one is your sympathetic postganglionic fibers. I hope you are writing this down. So you have sensory nerve supply and you have the efferent nerve supply, that is sympathetic postganglionic fibers. In the sensory, that is your primary nerve supply, you have to write your A delta fibers and the C fibers. A delta fibers are the ones which are located at the pulp dentine junction. Okay, they will be responding to the noxious mechanical stimulation. And the response by these A delta fibers will always be in the form of sharp pricking pain. Okay, sharp pricking pain. These are myelinated fibers and hence they are faster conducting and they are the larger diameter fibers. Am I audible to you all? Yes. So when you talk about the diameter is approximately, it is in the range of 2 to 5 microns and its conduction is 6 to 30 meters per second. So the diameter is 2 to 5 microns and its conduction is 6 to 30 meter per second. So that is all about your A delta fiber. Next is your C fibers. The C fibers are the ones which are located in about 80% of its strength. Okay, so they are more in number. They are present throughout the central part of the pulp. So they are 80% in its strength or in number. They are located throughout the central part of the pulp. Then these C fibers are ones which are unmyelinated. So that means they will be slow in their conduction. So they are unmyelinated, that means they are slow in conduction and they are of a smaller diameter. So their diameter is approximately 0.5 to 1 microns and their conduction is approximately 0.6 to 2 meters per second. Okay, diameter is 0.5 to 1 micron and conduction velocity is 0.6 to 2 meters per second. Then what you have to again know is that if the question says what are the polymodal fibers, so polymodal fibers are again your C fibers, because these are the ones which will respond to all kind of noxious stimuli, whether thermal, whether electrical, whether mechanical. Okay, so these are polymodal fibers. They are the ones which will respond to any kind of stimuli, and they will be responding in terms of pain only, but they respond to all types of stimuli, and their stimulation is generally associated with tissue injury. So fibers that are associated with tissue injury are your C fibers. Okay, so in normal course of time, when you have your healthy pulp, and whenever an electrical or a thermal stimuli is given, it's generally your A delta fibers which you are looking at. Okay, so in normal course of time, when you have a healthy pulp, it's your A delta fibers which give you the sharp pricking pain in response to stimulus. But when you have any pulpal pathology, when you have any tissue injury, in that situation it becomes your C fibers which become active, and then they respond to pain. Okay, so we have these. I hope this is very clear. A delta fibers, C fibers, which form your sensory nerve supply, and you have your and the second group is your efferent fibers, that is your motor fibers, which are the sympathetic postganglionic fibers. These are the fibers which are associated with the circulation, the vasculature of your pulp. Okay, so whenever there is arteriolar or whenever there is blood vasculature constriction, it is regulated through these sympathetic postganglionic fibers. I hope you all have written this entire thing very clearly. Some of the other questions will always be asked from these only, so you have to know about this. Your A delta fibers are your low threshold fibers. That means at any point of time, at any stimulus, it's the A delta fibers which get stimulated. It's only when you have tissue injury, then your C fibers will get stimulated. Okay, so they are the high threshold fibers. So A delta is the low threshold fiber. That means they require lower stimulus, and C fibers are the higher threshold fibers. That means they require higher level of stimulation. We go on to the next question. Up. Let's come up. The 14th question. Stratum intermedium cells are So this is a direct question. They are the squamous cells that are present between the inner enamel epithelium and the stellate reticulum. So 14th question, the answer is B. We go on to the next question. Dental papilla becomes the pulp at the answer. If you all can know the answer, you all can always post your answer whenever a question is raised, okay, so that you all can, in case if you all have not solved the question paper, you can still give the answer with your knowledge before an answer is given by me. Okay. Yes, at the moment the mantle dentine form. So we know that there are three types of dentine: primary dentine, secondary dentine and reparative dentine, or the tertiary dentine. Okay. Your primary dentine is again divided into two parts, the mantle dentine and the circumpulpal dentine. These are the dentine which are the first form dentine. The mantle dentine is the first form dentine, followed by the circumpulpal dentine. Both of these together form your primary dentine. That is that dentine that is formed before the root development. Okay, before the root development, you have your primary dentine which is formed. Then you have the secondary dentine. Secondary dentine is the one which is formed throughout life. Alright, secondary dentine is the one which is formed throughout the life. It is formed at a slower pace. So primary dentine is formed at what rate? 4 to 8 microns. Okay, Primary dentine is formed at the rate of 4 to 8 microns per day. Secondary dentine is the dentine that is formed throughout the life. Okay, it is the dentine that starts formation after the root formation is completed. And it is formed at the rate of 0.8 microns per day. It is formed at the rate of 0.8 microns per day. Alright, and then lastly you have the reparative dentine. So reparative dentine we had already discussed last time. We have two types of reparative dentine, reactionary tertiary dentine and reparative tertiary dentine. Reactionary is formed when you have a mild stimulus in response to that, and reparative is when you have a very moderate or a high level of insult to the odontoblasts that are present. So there is degeneration of odontoblasts and there is a newer recruitment of odontoblasts from the undifferentiated mesenchymal cells. So these reparative dentine is formed at a little better rate as compared to your secondary dentine. So that is 1.5 microns per day. So I hope you all have written the rate at which each of these dentine is formed. Primary dentine 4 to 8 microns per day, secondary 0.8 microns per day, and reparative is 1.5 microns per day. So I think now you should be able to answer the next question. Reparative dentine is deposited in the affected area at the rate of. Reparative dentine I had discussed in detail about in the conservative section. Yet again I am repeating. Reparative dentine, that is your tertiary dentine, is of two types. One is the reactionary dentine, which is formed in response to a mild level of stimulus. Okay, and it is formed by the odontoblasts which are already present in your pulp tissue. So they will be generally in a similar fashion. That means it will have the same number of dentinal tubules, the same matrix of your collagen fibers. Whereas reparative dentine, okay, is the one which is formed in response to a moderate level of a stimulus, moderate to a high level of caries or a stimulus, and that is when you have degeneration of the odontoblast and you have undifferentiated mesenchymal cells which then differentiate into the odontoblast. Do you all remember in how many days do these cells get differentiated? I had discussed this in detail. Do you all remember in how many days does the undifferentiated mesenchymal cells differentiate into odontoblasts? Yes, it is 15 days. 100 days it takes for the reparative dentine to be formed. The question is that it takes 15 days for the undifferentiated cells to convert into odontoblasts. These odontoblasts will then take about 100 days to form the reparative dentine in a section of 0.12 millimeters thickness. See, it becomes very important that you'll keep filing your notes and you'll keep filing it with a little highlighted topic to it, you know, because when you write it in a very small handwriting or when you just let go of a particular numeric, these are the ones which will be asked in your question paper. So you have to ensure that these numerics, these titles, these subtitles are written in a very eligible handwriting so that you can read it as and when required. We go on to the next question. The demarcation zone between secondary and reparative dentine is. So that is your calciotraumatic line. Go on to the next question. Collagen fibers of the young pulp have affinity to silver stain because of. Collagen fibers of young pulp have the affinity to silver stain because of their carbohydrate content. They can also ask you, instead of silver stain, they can also ask you the argyrophilic stain, that is the silver loving stain. A very commonly way of asking. Silver stain, also called as argyrophilic stain. Next. Shovel-shaped coronally placed pulp with 3 short horns on the coronal roof is a feature of. So there is only one tooth which has just 3 pulp horns, and that tooth is your maxillary central incisor. The only tooth which has 3 pulp horns is your maxillary central incisor. If they ask you that the highest pulp horn for the maxillary molar, that is your mesiobuccal pulp horn. Okay, highest pulp horn, or the pulp horn which is most likely to get exposed during cavity preparation in maxillary first molar is your mesiobuccal. And a similar question for the mandibular molar, that is your highest pulp horn in the mandibular molar, or the pulp horn which is most likely to get exposed during cavity preparation, that is, can anybody tell me? Mesiolingual, yes. Mesiolingual for the mandibular molar and mesiobuccal for the maxillary molar. Maxillary molars have roughly what shape of cervical cross section? Next question, the 20th. Maxillary molars have roughly what cervical cross section? Okay, here the answer is wrongly printed as rectangular, it is rhomboidal. Please note the answer to the 20th question is rhomboidal. This is from Cohen. Okay, your Grossman gives you rectangular, but actually maxillary molars have roughly a rhomboidal shape with rounded corners. If the question says that the cross section for mandibular molars, it is triangular when it is 3 rooted, and when it is 4 root or 4 canals is present, then you have trapezoidal. Please write it down. For maxillary molars it is rhomboidal. For the mandibular molars it is triangular when you have 3 canals. Triangular when you have 3 canals, and it is trapezoidal when you have 4 canals. Is that clear? Trapezoidal when you have 4 canals. Have you all written this down? Yes. There should not be any confusion. See, rectangular is the shape of a tooth, but rectangular by Cohen is not a particular cross section which they have mentioned. Okay, probably in your mandibular second molar you can call it as rectangular when you have 2 canals. Okay, but it is by Cohen, it is only the shapes of rhomboidal, trapezoidal, or triangular which are the ones which are used. Okay. Rectangular, you can use it only when they are calling this mandibular second molar with 4 canals. Okay. Smallest pulp in the dentition is mandibular central incisor. And the largest pulp in dentition is present in, can anybody tell me? Largest pulp in the dentition? I want the answer for the largest. These are the answers which I had given you all in the last discussion. So that's why I'm just trying to recapitulate it with you all. Largest pulp is with the maxillary first molar. Yes. If I question it as largest pulp in a single rooted tooth, largest pulp in a single rooted tooth, then that answer would be largest pulp in a single, yes, maxillary canine. So, smallest pulp in the dentition is mandibular central incisor, largest pulp in the dentition is maxillary first molar, and largest pulp in a single rooted tooth is a maxillary canine. Go on to the next question. Dehydration may be caused by restorative materials such as cavet, because the answer to your 22nd question it is hydrophilic. So there are a lot of ways of asking about cavet. Firstly, tell me how much should be the ideal thickness of any temporary restorative material. The minimum thickness that is required for any restorative material or particularly cavet is, I need the answer to my question, 3.5 millimeters. Yes. So 3.5 millimeters. Now cavet as a material, it is a combination of three things which you should know. It is zinc oxide, calcium sulfate and polyvinyl acetate and polyvinyl chlorine. Okay, I hope you all are writing it down. Cavet, by the composition, it is a combination of zinc oxide, calcium sulfate and PVC, that is polyvinyl chlorine and polyvinyl acetate, PVA. So zinc oxide, calcium sulfate and PVC, that is polyvinyl chlorine, and PVA, that is polyvinyl acetate. Now, by virtue of its calcium sulfate content, it has a tendency of absorbing moisture and in fact even swelling. So that is the reason why you should have that there is a good amount of tooth structure around a temporary filling, because it is very commonly seen that cavet, or in fact you can always, there can be a question which is asked that if you see that a tooth structure has been broken down after a placement of a temporary restorative material or after the placement of a cavet, that is because it absorbs moisture and it swells. So whatever is the supporting tooth structure around it, it may tend to fracture it by virtue of its swelling action. Okay, so cavet should always be having good amount of tooth structure which is supported it, and it is hydrophilic in nature because it is moisture loving, it absorbs water and it swells. There was a question that which is the maximum efficacy is present with temporary restorative material, and that was calcinol. This is as per an article which was given in an international endodontic journal. Okay, calcinol, it is a reinforced type of a ZOE restorative material. Okay, it is a reinforced ZOE material, and it is apparently, according to the studies, having the maximum sealing effect. By any means, a temporary filling should not be exceeding more than 2 weeks of a restoration. Okay, any temporary restoration should not be exceeding more than 2 weeks of a interval. Alright, so 2 weeks is the maximum time a temporary restoration material can be inserted into a cavity, and then it requires a change of dressing. So I hope this is clear about cavet. These are the few things that will be generally asked about cavet. Maybe it's composition, maybe it's hydrophilicity, okay, the thickness that is related to it. You go on to the next question. See, it is not related to any particular cement, whether it is calcinol, whether it is cavet, whether it is IRM, it should be 3.5 millimeters only. That is by means of Cohen. Cohen says that any temporary restorative material should be in a thickness of at least 3.5 millimeters. So it is not to be something that, we keep it temporary specific. If a temporary restoration material is kept for long, it is a temporary material. There has to be a certain limit to what any restoration which is being called temporary has to be inserted into the cavity. So that is by various studies. See, these quotations of thicknesses, days is always by means of researches and studies. So if you keep it for longer, probably the purpose of why you are putting a temporary restoration material, that will not get fulfilled. A temporary restoration material is something that it should be able to provide you the coronal seal against leakage. So if you're keeping a particular restoration material beyond the required time, then it will lose its seal and there will be micro leakage again. Most frequent chemical cause of pulp death in an incisor teeth is, yes. So as we know, silicate restoration, which was the oldest of the tooth color restoration or the oldest of the cements, it is a cement which has the lowest pH of all the cement. So if the question is that maximum chemical insults or maximum or the lowest pH of any cement is your silicate restoration. So among all the options, it is a silicate restoration. Again, the question is that which is most kind to the pulp? Which of these cements is the most kind to the pulp? What will be the answer? The restoration that is most kind to the pulp. Yes, it will be polycarboxylate. Good. True about stannous fluoride is to prevent decay and pulp. Next question, true about stannous fluoride to prevent decay. So this is from the chapter from Grossman. It is out of all the various insults, that is physical, thermal, chemical, biological. Okay, so, among the chemicals, when you have these etchants, when you have these stannous fluorides which are used to prevent the decay, it is just said that these fluoride applications, when they are applied for less than 5 minutes, then it is a lesser chance that the tooth will have any chemical insult. So that is, it will not be dangerous to the pulp if applied for 5 minutes. It's a direct textbook question from Grossman. Next question, true about sensitivity of polypoid tissue is? True about sensitivity of polypoid tissue is? So polypoid tissues, which is actually present in your pulp polyps, that is your chronic hyperplastic pulpitis, these are the tissues which are less sensitive than the normal pulp, but they will be more sensitive than gingival tissue. Why will they be less sensitive? That's because the neural supply is already in the mode of degeneration. So they are generally less sensitive than your normal pulp because of the degeneration of the nerve supply. But they are generally more sensitive than your gingival tissue. Next question. True about incidence of radicular cyst is, or radicular cyst is most commonly present in, more common in the maxilla. Why more common in maxilla? Can anybody tell me? Why more common in maxilla? Yes, because maxilla has more cancellous bone, so that is the reason why it will have unhindered spread of infection, and as a result you have maxillary bone is more prone to, due to cancellous bone. What is the occurrence rate of radicular cyst in periapical pathologies? What is the occurrence rate? The occurrence rate of radicular cyst in any periapical pathology is 6 to 55%. That you should also know. 6 to 55% is the occurrence rate of these radicular cysts in periapical pathology. We go on to the next question. On the radiograph, the facial root of the maxillary first premolar would appear distal to the lingual. So, how is the head angulated? So this is very commonly known as your slope technique. Okay, please write down the names to various names to the slope technique or the Clark technique or the Wharton projection. Okay, Clark technique or the Wharton projection is same as your slope technique. That means the same side of the X-ray head will be the lingual root, and anything which is going in the opposite direction is your facial root. Okay, so if you have a premolar which has a buccal and a palatal root, okay, if I take my X-ray tube head towards the mesial side, so it will be my lingual root which will be going in the same direction as the tube head. That means even the lingual root will go mesial and the distal root and the facial root will go towards the distal. So same side lingual, opposite side buccal. It is also called as the Clark projection or the Clark rule and Wharton projection. These names are given in English, so you should be knowing the alternative names to these. We go on to the next question. Accurate differentiation of different periapical lesions can be made by? Yes, very logical question. Accurate differentiation, or the gold standard, Wharton, W-A-R-T-O-N. It's W-A-R Wharton, W-A-R-T-O-N. So accurate differentiation, or I would say gold standard for any diagnosis, is your biopsy or histologic examination. Okay. The 27th question is your, yes, it's Wharton projection. 27th question is basically based upon your slop technique, that you can imagine a premolar which has a facial root and a palatal root. Okay, now if I take an X-ray tube head and if I want to shoot an X-ray of a premolar, if I take the X-ray tube head on the mesial side, on the IOPA, what I will see is that your palatal root is seen on the mesial side of the X-ray and the facial root is gone onto the distal side. So that is a slop technique. That means that wherever the X-ray tube head is being taken, or whichever side the X-ray tube head is shifted, the root which is lingual or palatal which gets shifted to the same side, and the root which is on the facial or the buccal will get shifted to the distal side. So if I take the X-ray tube head towards the distal position, then the palatal root will take a distal position and the facial root will get onto the mesial side. Accurate differentiation of different periapical lesions can be made by histologic examination, or this question can also be asked as gold standard for diagnosis of various periapical lesions is made by biopsy. True about radiographs that are used in endodontics. 29th question number. See, these are direct questions. Let's just roughly go through them. True about radiographs used in endodontics is periapical radiolucency does not indicate diseased tooth at all time. Why so? Because sometimes you can see radiolucencies which are of mental foramen, incisive foramen. Okay, so these all radiolucencies are not a diseased or a pathology state of a condition. The second option, lesions in the cancellous bone can be detected easily. Again, that is false, because you require at least 33% of demineralization for any cancellous tooth structure to be seen onto the X-ray. So you require 33% of a demineralization for a cancellous tooth structure to be seen. And third is, of course, it does not give a true picture. True picture is seen by biopsies. Next question. In thermography, what is used to determine the vitality of a tooth? So at this point, you just have to first write down that there are three tests which are sensibility test. See, according to your 6.6% is according probably to Studevant. According to oral pathology, they say that there should be a 33% of your 6.6 is also not wrong, but according to oral, your Schaefer's, they say 33%. So accordingly, you'll have to make a choice. If you have your options which is in the range of 6.6, 7, 8, 9, then probably you can pick 6.6. If you have your options in the range of 33, 63, 50s, then according, because different books have a different kind of gradings. You know, these values are always in terms of grading. So accordingly, you have to pick your option, 6.6 or 33%. Okay, so what I was saying is that whenever pulp testing is done, it can be of two tests, sensibility test and true vitality test. Sensibility tests is your thermal test, electric pulp tester and test cavity. I hope you all are writing this down. Sensibility tests are your thermal test, that is hot and cold test, then your electric pulp tester and your test cavity. So what do you mean by sensibility test? That means they will be checking only the neural supply, whether you have an intact neural supply, that is your A delta and C fibers. See, it's a very clear. So these tests are not your vitality test. They are your sensibility test. So then what are the true vitality tests? First is your laser Doppler flowmetry. Okay. Laser Doppler flowmetry, that is LDF. Second is your pulse oximetry. Pulse oximetry. Then third is your thermography. Third is your thermography. And the last one is the wave spectrography. Wave spectrography. So you have your laser Doppler flowmetry, pulse oximetry, then thermography, and your wave spectrography or wave spectrometry. So the answer in this thermography is crystals. So what is, see, each of these individual ones I will explain to you when the right question comes. For now, what I will explain to you is what is thermography. So in basically thermography, what they do is that you have these cholestric crystals, okay? Cholestric crystals are present. These crystals have the ability of changing their color when they come in contact with the tooth surface. Now, how will they change the color? Depending upon the temperature of the tooth. So warmer the tooth structure, that means you have better vasculature, that means the tooth is still vital. So there will be a change in color as compared to tooth structure which is not warmer or which is cold or which is necrosed. Okay, so in thermography you have these crystals which are the cholestric crystals. These crystals have the ability of changing their color, and they change color as according to the temperature of the tooth structure. So you have, when you have the warmer tooth structure which is present, that is indicative of a pulp vitality, and they will change color. And when you do not have a change in color, that means it is indicative that the tooth is non-vital. Okay, that means the temperature is on the colder surface, on the colder side. Is it clear what is thermography? So these are these cholestric crystals. Okay, so we go on to the next question. In a radiograph of maxillary central incisor, area of rarefaction is present over the central. All tests are negative and the tooth is asymptomatic. It is suggestive of, I have told you that I will explain the other types of tests as and when the relevant question comes. So the answer is your incisive foramen. In the radiograph of the maxillary central, it is the area of rarefaction. There can be another way of asking this question. Another way of asking this question is, which is the condition or which is the pulpal condition which is the most difficult to diagnose? Okay, so the condition which is most difficult to diagnose would be chronic pulpitis, because this is the one which will be mostly asymptomatic on all of your testing. So the condition or the pulpal condition which is the most difficult to diagnose is your chronic pulpitis. Next, according to Dachi and Associates, a 1/4 inch diameter of ice placed against a tooth is sufficient to quantify what? Area of rarefaction is nothing but a radiolucency, loss of trabeculation, that is rarefaction. Okay, now at this point let me tell you what is cold test and heat test. As I've already said, see, please ensure that you're writing everything down as I'm saying, okay? Your cold test is a test which will indicate whether a tooth is vital or a non-vital, okay? Irrelevant whether it is normal or abnormal. So if a tooth is responding to a cold test, that means it is having vital tissue, okay? If a tooth is not responding to cold, that means it is necrotic or it is not having vital tissue. So cold test will differentiate first between a vital tissue and a non-vital tissue. If it tells you it is a vital tissue, that means it is responding. It is not relevant or it is not indicative whether it is normal or abnormal. Okay, and when it is not responding, it is a form of your non-vital tissue. Now, according to what kind of response you will get on your cold test, it will determine whether it is a reversible form of a pulpitis or whether it is an irreversible. So, cold test again will be able to tell you whether it is a reversible pulpitis or an irreversible pulpitis. So, when you apply a cold tester and patient experiences pain, but the pain goes away immediately on the removal of stimulus, that is your reversible pulpitis. So reversible pulpitis will show that when a cold testing is done, patient will experience sharp pain and the pain goes away as soon as the stimulus is removed. Okay, and if this pain continues in the form of a lingering phase, okay, if it continues for beyond the removal of the stimulus, then that is a irreversible pulpitis. I hope you all are putting arrows and writing this down. Pain going away or pain disappear on the removal of stimulus is your reversible pulpitis, and pain lingering is your irreversible pulpitis. So the treatment plan for reversible pulpitis will be removal of the cavity and placement of a sedative dressing. Okay, very commonly this question is asked, that if you see that the caries is extending or approaching the pulp one but not completely involving the pulp, okay, so that is a form of a reversible pulpitis in which the tooth will be accordingly reacting to what I have said. So in that situation, you only remove the cavity and you put a sedative dressing or a ZOE dressing, and in irreversible pulpitis you will do pulpectomy. So this is understood between what cold test is done. Now, apart from this, what exactly is cold testing targeting at? Your cold testing is generally targeting at the dentinal fluids that are present in the dentinal tubules. So whenever you apply cold, there will be contraction of those fluids, and because of that contraction of the dentinal fluids, it will result in the stimulation of your A delta fibers, which are located at the pulp-dentine junction. Okay, so right there, cold test, contraction of the dentinal fluids, stimulation of your A delta fibers at the pulp-dentine junction. तो ये हो गया आपका mechanism. Then we come to the tools. There are 5 things that can be used for cold testing. First is your cold water. Second is your ice stick. So cold water, ice stick, you can club it together. Okay. Then second one is your DDM, that is dichloromethane. DDM, that is also called as endo ice. That is also called as endo ice. That temperature is minus 50 degrees centigrade. Are you all writing it down? Endo ice, that is DDM, is minus 50 degrees centigrade. Then you have something called as green endo ice. Green endo ice, that is your tetrafluoroethane. Tetrafluoroethane, okay. That tetrafluoroethane has a temperature of minus 26.2 degrees centigrade. This is the one which is most popular or most commonly used. So you have to remember tetrafluoroethane. It is called as 1,1,2 tetrafluoroethane. Okay. This is the one which is most popular, most commonly used. It is also called as a refrigerant spray. It is also called as a green endo ice, and it has a temperature of minus 26.2 degrees centigrade. DDM was difluoromethane. Okay. DDM was difluoromethane. Then apart from this, next is endofrost. Endofrost is PBM, that is propane butane mixture. Propane butane mixture, that is your endofrost. That also has a temperature of minus 50 degrees centigrade. Okay. And lastly, you have the carbon dioxide snow, or you have the dry ice. Carbon dioxide snow or the dry ice, that is minus 78 degrees centigrade. So did you all write all of these? Your ice stick or your cold water, which is at 0 degrees centigrade. Then you have DDM or the endo ice, which is at -50. A similar temperature is that with the PBM, that is propane butane mixture, -50. That is called as endo frost. फिर green endo ice was your tetrafluoroethane. This was basically, we all know that DDM has a lot of greenhouse effect, because of the difluoromethane. इसलिए you had a more ecological modification to it. That was your TFE. That has a temperature of -26.2. This is also called as a refrigerant spray. It is most commonly or most popularly used. Okay. And finally, you have your carbon dioxide snow or your dry ice. So this is -78 degrees centigrade. Okay. Now, if my question is that which is the one which is most commonly used or most popularly used, or the ones which is used as, yes, somebody is really paying attention to all the numbers. That's very good. Okay. My question was that the type of cold tester which is used for your PFM crowns or under restorations, then what again there the answer would be, it will be your green endo ice only, that is 112 tetrafluoroethane. Okay. The tester which is now advised to be used under your PFM restorations, under your ceramic restorations, or any type of crowns for that matter, is most commonly picked up as your green endo ice, that is 112 tetrafluoroethane. Is that clear? Okay. And last aspect to your cold tester is that it should be applied not more than 5 seconds. Okay, not more than 5 seconds. Endo frost is your PBM, that is propane butane mixture. It has a temperature of -50 degrees centigrade. Alright, so now we move on to the next question. I hope your cold tester is completely understood here. Okay, now since we've already spoken about cold testing, we will also speak about heat testing. Okay, so we now know that cold testing will differentiate whether the tooth is vital or non-vital. Whether it is abnormal, normal is not the concern. If a tooth is responding to a cold tester, it is vital. Then depending upon what kind of pain it is showing, whether it is pain which is disappearing or pain which is lingering, you call it reversible, irreversible. तो अब heat testing क्या करती है? Heat testing is something which is, if a tooth will respond to heat, it is indicative that there is some form of tissue injury. That means it requires an endo treatment. So if a tooth responds to heat, it is not a test which will check the vitality. Heat testing is not to be used to check the vitality. If a tooth responds to heat, that means it is already diseased. Okay, write it like this only. If a heat test is done and the tooth responds to heat, it is already diseased, and that requires an endo treatment. Again, your heat test will always show you a biphasic response. I'm coming to that your heat test will always show you a biphasic response. That means when you start applying heat, okay, initially there may not be any pain, but as you cross your 5 seconds, excuse me, but as you cross your 5 seconds, initially there is going to be stimulation, as I said, of A delta fibers. That A delta fibers will initially start giving you a sharp pain. As you go on applying your heat, it will be your C fibers which will start showing stimulation, and that is the time when you will experience extremely gnawing, very dull, lancinating kind of pain. So heat response will always be a biphasic response, in which initially you will have very sharp kind of pain because of A delta fibers, and then when the continued stimulation happens, it will be the C fibers which starts responding, because you already know that there is some tissue injury which has happened, and that will start giving you your dull aching, your very lancinating kind of a pain. Okay, so heat should always be applied less than 5 seconds, and when it is applied, and if there is any tissue injury, you will have a biphasic response. Alright, and heat test response will always say that yes, you do require some kind of endodontic therapy. Alright, apart from this, what I would like you all to write is that what should be the temperature that is maximally tolerable by the pulp, and what is the temperature that is actually required for this heat and cold test. So Cohen says that temperatures ranging from 16 degrees centigrade to 55 degrees centigrade. Temperatures ranging from 16 degrees centigrade to 55 degrees centigrade. They are well tolerable by the pulp. 16 Baba, so your heat test, see, as I told you, your C fibers will never respond unless there is a tissue injury. I told you in my beginning of my neural supply only. Whenever you apply your stimuli, whether thermal, electric, it's only your A delta fibers which will be responding. मिनट जब आपको पेशेंट आपको बोलता है कि मुझे पेन हो रहा है, तो आप हटा दोगे उसको. डिपेंडिंग अपॉन कि उसने कितनी देर में या कैसा पेन बताया, आप उसको डिसाइड करोगे कि रिवर्सिबल है, इरिवर्सिबल है. बट अगर वही 5 सेकेंड्स में पेशेंट ने आपको डल एकिंग पेन बताना शुरू कर दिया, that means there is a stimulation of C fibers, and that means C fibers are always associated with some kind of tissue injury. In my beginning only I said that C fiber stimulation which gives you dull or lancinating pain is always associated with tissue injury. So the minute if I am putting a heat and the patient is saying that I am having dull pain, lingering pain, lancinating pain, that means my C fibers have already got stimulated, and that means it requires an endodontic therapy. Okay, so that is the whole funda of your heat testing. Now what I was saying is about your temperature. Temperature is 16 to 55 degrees centigrade is considered to be tolerable by the pulp. Any 10 degree rise in any direction will be something which is required for your cold and heat test. That means cold testing always requires temperatures at 5 degrees centigrade or anything below it, and heat testing will always require temperatures of 65. So cold test, it should always have temperatures of 5 degrees centigrade or below it, and heat test should always be 65 degrees centigrade. That means the tooth will respond in terms of pain when you have temperatures of 5 to 65 degrees centigrade. Is that clear? Your normal temperature range which is tolerable by the pulp is 16 to 55 degrees centigrade, and tooth response in terms of pain when you have temperatures of 5 degrees centigrade for cold and 65 for the heat. One thing you have to note here is that you have to know the conversion of degree centigrades to Fahrenheit. Please ensure that you remember the conversions of centigrade to Fahrenheit or Fahrenheit to centigrade, because these values which I have given to you is bang on, very accurate. So whenever they ask you a question, they may not ask you in terms of centigrade, they may ask you in terms of Fahrenheit. So you should know the conversion, and effectively you should write whatever the number is. So I am repeating the temperatures, okay. Temperatures that are tolerable by the pulp is in the range of 16 to 55 degrees centigrade, okay. Heat testing requires temperatures of 65 degrees centigrade. We all know that any rise of 10 degrees centigrade from the baseline will elicit pain or any pulpal response. We all know, we have always known that 10 degree centigrade rise of any temperature from the baseline will always elicit pulpal response. So what is this baseline? Baseline is your 16 to 55 degrees centigrade. Heat testing will elicit pain at 65 degrees centigrade and beyond, and cold testing will elicit pain at 5 degrees centigrade and below it. Okay. You should know the conversion to Fahrenheit. We go on to the next question. Engine-driven latch type drills are similar to engine-driven instruments except that you can Google and find out how to convert centigrade into Fahrenheit. We will not get into the physics of conversion of centigrade into Fahrenheit. Engine-driven latch type drills are similar to engine-driven instrument except that in engine-driven latch type, the answer to your 33 number question. We need to move on to the next questions. There are a lot of other discussions that come your way. So let's move on. Okay, so we know there are four types of, there is a classification which is given by Cohen for the various endodontic or rotary instruments. So write down, you have to know this classification. There are four types of classes for your endodontic or your rotary instruments. Type 1 is your hand instruments. Okay, type 1 is your hand instruments. That is your K file, H file, broaches, reamers. Okay, so first group is your group 1 is your hand instruments, which are your K file, H file, reamers, broaches. Then your second are all of these instruments only which are to be attached in a handpiece. Are you writing it down? So hand instruments which have a latch type of attachment, which will be now then attached to an engine driven handpiece. So group 2 are your hand instruments which have a latch type of an attachment, and these are to be attached in your engine driven handpiece. तो इसमें आपके सारे rotary files आ जाते हैं, your pro tapers, your pro files, so they all have these latch to be a latch type of a back or a backside, which will be then attached to your engine driven handpiece. Then you have your group 3. Group 3 is your those instruments which have a latch type attachment attached to which to be attached to your engine driven handpiece, and they will all be in a single piece, that is your gates glidden and your piezo reamers. So engine driven latch type of drills which are all in a single piece of metal. Group 3 क्या है? Engine driven latch type drills which are all made in a single piece of metal. तो इसमें आपके दो ही आते हैं, gates glidden burrs and your piezo reamers. And lastly, you have your root canal obturators, your spreaders, your GP points, your pluggers. So group 4 are your obturating ones, that is your pluggers, your spreaders, your GP points, your silver points. Have you all written this 4 classification? Very commonly will they keep asking you about any group 1, 2, 3, 4, or they may ask you something related to it. Okay. We go on to the next question. In order to provide more resistance to torque, small instruments are manufactured from. The 34 question number. Class 3 is your gates glidden and piezo reamers. Okay. They are your latch type of instruments which are made in single piece of a metal only. Like if you see a pro taper has a different handle and a different cutting edges or the flutes. So that is your group 2, which is your hand instruments which have that which have the addition of a latch type of an attachment. Group 3 are made in a single piece of metal like your piezos and your gates glidden, and they can be directly attached to your hand pieces. In order to provide more resistance, okay, so at this point you should know, very commonly they will ask you one question about your files and reamers. So write down firstly that whenever you talk about your files or whether you talk about your reamers, they are always the cross section which you should know. The cross section for a reamer is triangular. The cross section for a file is your square. That means a reamer which is triangular, it has a higher cutting efficiency, okay, but at the same time, because uska cross section is very small, okay, it has very small, so that means it has a higher susceptibility of fracture. Okay, so reamer which is triangular in its cross section will have better cutting efficiency but lesser resistance to fracture. That is the reason why you have the development of files. Files, because they are now made in a squarer cross section, they will have a better resistance to fracture. But because you have a square shape, that means you have 4 number of flutes, it will result in a reduction in the cutting efficiency. So files will have a lesser cutting efficiency as compared to a reamers, but at the same time they have a better resistance to fracture as compared to reamers because of a better central core area. Have you written this down? बहुत commonly पूछेंगे which has more number of flutes, which have lesser number of flutes. So which will have more number of flutes and which will have less number of flutes? Your reamers which have triangular cross sections have lesser number of flutes, and that is the reason why it has better cutting efficiency, because it can take a lot of dentine debris between its flutes. Okay, they are spiraled in a very loosely ended fashion, whereas your files which have tighter flutes, your files have a more tighter flutes, they have more number of flutes. So that is the reason why they have lesser cutting efficiency, because there is lesser area for the dentine to be removed and collected. Okay, तो ये भी हो गया आपका more number of spirals, less number of spirals, more in files, less in reamers. Then what will be the cutting motion? Reamers are always used in a cutting motion of PRR, that is penetrate, rotate and retract. आप लोग लिख रहे हैं ये? Penetrate, PRR is the motion for your reamers. Okay, that is penetrate, rotate and retract. And your files are used in rasping motion, or you call it as the push-pull motion. Okay, that means you insert the file in the canal and you just engage the dentine circumferentially and you pull it out. Okay, so insert. Yes, I know I had given it, but I don't know whether you all remember it. So I hope if you all have written it down, it's good. Okay, so you have your rasping motion. So you have your reamers and your files. I'm happy that you remember everything that was said and written in the last lecture. Okay, so we go on to the next question. Next question. The tip size of greater taper hand files. Is ISO size 20 or 0.20 millimeters. Okay, at this point you should just write what are the cross sections of various instruments, or probably what can be the probable question that can be asked for your rotary files. Okay, so whether it is profile or whether it is greater taper profiles. Okay, these come in. Profile was the first rotary instrument which was introduced with a constant taper of 29%. Okay, profiles were the first rotary instruments that was introduced in a constant taper of 29%. Alright, then you had the greater taper files. Greater taper files were used to be more precisely, they were used with they were to be used in straight canals for additional coronal flaring. Okay, and they, as the name suggests, are available in a greater taper. That means they extend from 4% taper, 6% taper up to 12% taper, and they all are available in tip sizes of 20. बाकी आपके सारे rotary instruments tip sizes में 20, 25, 30, they will all be available in almost all sizes. But your GT files or your greater taper files are available only in the tip size of 20, and they vary up to 4 to 12%. They are precisely to be used in the straight part of the canal, that is for coronal flaring. ये तो हो गया इनके sizes का. इसका क्रॉस सेक्शन कैसा है? इट इज अ ट्राइहेलिकल सिमेट्रिक फ्लूट, ट्राइहेलिकल सिमेट्रिक फ्लूट विथ रेडियल लैंड्स. ओके, profiles along with light speed, profiles along with light speed are the only files which have trihelical symmetric flutes, and they also have the radial lands. Okay, profiles along with light speed are the only files that have trihelical symmetric flutes. They have radial lands and they will also be having negative rake angle. So what does all this mean? Because they have a negative rake angle, they will not be having good cutting efficiency. They will always be just scraping against the wall. Okay, they will only be scraping against the wall. So आप ये इसका लिख लो कि whether they ask you about profiles or GT profiles or your light speed, your cross section should always be remembered as trihelical symmetric flutes, negative rake angle and radial lands. That means their cutting efficiency is not very good. They will be generally scraping against the walls. Sizes, all these files are available in various other sizes. It's only the greater taper hand files that are available only in tip sizes of 20. Rest all your rotary instruments vary in sizes right from 15 to 20 to whatever endodontic instrument size you wish to use. Okay. Apart from that, so ये हो गया आपका negative rake angle. Apart from that, you have to know about Quantec, K3, Hero 642, Protapers, your race. Okay, so इसमें लिखो Quantec. What is Quantec? Quantec is a double helical. Quantec is double helical file with asymmetric flutes. Quantec is a double helical file with asymmetric flutes, and it is a file which has a positive rake angle. तो अगर asymmetric है तो that means it will have a higher resistance to fracture, and it has a positive rake angle, that means it will have better cutting efficiency. So I hope you all have written Quantec. It is a double helical, that means there are only two flutes to the file, and that too it is asymmetric. Okay, and this has positive rake angle. Next you write K3. K3 is very similar to Quantec, but it has three asymmetric flutes. So K3 has, it is a trihelical asymmetric fluted. It is trihelical asymmetric flutes. Again, it has a positive rake angle, and K3 is known to be the most resistant to fracture and highest in its cutting efficiency. K3, because it has asymmetric flutes, it will result in less of that screwing effect. Okay, less of screwing effect of a file into the canal, and as a result of which there is going to be a better cutting efficiency and higher resistance to fracture. That is your K3. Then you have your Protapers. Protapers I had already discussed last time, but I want to stress on the cross section. Cross section आपका है convex triangular. They have negative rake angle and they have no radial lands. Whereas जो आपके K3 और Quantec था, वहाँ पे recessive radial lands थे. मतलब your lands were slightly relieved. They were not completely, जैसे आपके profile और light speed में proper radial lands थे. In K3 and Quantec you have recessive lands. That means they will not be extending completely up to the circumference of your file. Whereas your Protapers have no radial lands. Okay, they are convex triangular in cross section with a negative rake angle. Alright, then we come to Hero Shapers. Hero Shapers, that is 642. 642 is indicative of its 642 is by means of its percentage, that is your 6%, 4% and 2%. So Hero का full form है high elasticity in rotation. That means these files, they have a very good amount of flexibility. Okay, they also have trihelical flutes which have recessive lands. Hero Shapers also, they are very similar to your Headstrong files, very similar to your H files. They also have trihelical trihelical cross section. They also have recessive flutes, okay, and they are also having a high resistance to fracture because they have a high flexibility. And lastly, what you should remember is your race files. Race is something which is very commonly asked in your papers. Okay, race is a file which has alternating high and low flutes. Matlab, if you see a race file, it will be something that at one cross section it will be touching the canal, then the next cross section it will not be touching the canal. Okay, so you have alternating high and low flutes. रेस का आपको फुल फॉर्म पता होना चाहिए. इट इज अ रीमर विथ ऑल्टरनेटिंग कटिंग एजेस. इट इज अ रीमर विथ ऑल्टरनेटिंग कटिंग एजेस. So that is about your race. It is triangular in cross section. It has no radial lines. It is triangular in cross section. It has no radial lines. It has alternating high and low spirals, due to which it will prevent any screwing action. Okay, and yes, its full form, that is reamer in an alternating cutting edges. Recessive flutes, as I said, it is intermediate between no radial lines and radial lines. जैसे आपके प्रोफाइल और लाइट स्पीड में रेडियल लैंड्स थे, वैसे ही आपके K3 और क्वांटेक और आपके हीरो शेपर्स में you have recessive flutes. That means that radial lines will have some degree of relief. They will not be completely land area to provide the clearance. Okay. So recessive flutes are the ones where the radial lines will be having the relief. That means the flutes from the radial axis will not be completely stretching up to the circumference of the file. That is your recessive flute. I hope you all have written the cross section, okay, and few features which I mentioned about these rotary files. In your exam, one of these will only be asked. See, the entire concept of these files or the mechanics of these files is something which is beyond the scope of our lecture. But what is asked in the exam is these few punch words. Okay, K3 का जो asymmetric flutes है, okay, protapus का जो convex triangular है, race का जो triangular है, alternating high low flutes है. So these are the things which you should be knowing. Okay, these are the things which you should be remembering, the punch words. Rest, the entire mechanics is something which you may not be able to remember also. So we go on to the next question. The 12% GT file is suitable for which type of canal orifice? The answer to the 36th question, we've already said that GT files, that is your greater taper files, are always used in the straight part of the canals. Because of their larger taper, they cannot be used in the curvature of a canal or in the apical third, otherwise it will break. Disadvantage of a racer contra-angle handpiece is so your racer and your gyromatic, they are the two contra-angle handpieces that are used in a reciprocating fashion, and their only disadvantage is that they can force the debris ahead of the instrument, resulting in clogging. Okay. Your racer and your gyromatic handpieces are your reciprocating handpieces. They have good cutting efficiency in preparing the canals because of their reciprocating action. Okay, but the only disadvantage of these contra-angle handpieces is that they can push the debris ahead of the canals. Go on to the 38th question. Motion of the file that is used with ultrasonic instruments. More than this question which is given in your MCQ, the very commonly asked question is that the motion that is used with your piezoelectric ultrasonics or the motion that is used with your magnetostrictive. So you have to write down here that ultrasonic instruments can be of two types, piezoelectric or magnetostrictive. Piezoelectric ultrasonic is more efficient, it is less heat producing, and it is used in a linear back-forth movement or the push-pull movement. So piezoelectric ultrasonics, which are more efficient in cutting, they generate lesser heat and they are used in a linear back-forth motion or a push-pull stroke. And your magnetostrictive have a lesser cutting action. They are used in an elliptical or a figure of 8 motion. Elliptical or a figure of 8 motion, and they are more heat producing. Okay, so magnetostrictive, they are less efficient as compared to piezoelectric. They are used in figure of 8 or elliptical motion, and they are more heat producing. You should also know the range of frequency with which these ultrasonic instruments are used. That is your 25 to 40 kilohertz. Okay, 25 to 40 kilohertz. Whereas your sonic instruments,